there seems to be a good feeling about nihilism about this. For the years before we knew all these other options, most of these patients were put on a proton pump inhibitor, dilated every few years or so. They didn't go to the allergist. They didn't have food elimination diets. They didn't take steroids that seem to have to be kept on forever. So for most of these patients, they're very happy with a physician who tells them, you don't have to do much, just see me every few years. The dilations, for those of us who do a lot of them, go well. The patients are happy. I'm wondering how awful this recommendation can continue in the year 2019. I continue to feel guilty about this fairly conservative approach for these patients.
Actually, I don't think you should feel guilty. It turns out that the studies that look at PPIs, the remission rate's over 50%. So the first thing I would do is try a PPI. And, you know, the approach of PPI and intermittent dilation has proven to be an effective therapy.
It also allows me not to have to make any changes and rescope them and biopsy and figure out how many eosinophils they have after every change in therapy. I can almost ignore everything unless the patient really does poorly.
So I think that one maybe is going to change in the future. There were a couple of abstracts suggesting that if you follow these people up closely with endoscopy and biopsy, you can decrease the need for dilation. And there's some evidence out there that if you suppress their eosinophil counts into the normal range, that you have fewer complications over time.
Tell them not to drink milk now. That's the one thing I've learned today.
Yeah.
One other thing, keep in mind what's important, EOE, it's not a malignant disease, it's benign. I have a few patients, young, who do not want to be on any medication. They want only dilation. A good dilation to 16, 17 millimeters Savory will keep them okay for a year or two. And this is perfectly reasonable strategy for those who do not want to be on anything. And it could be that in a few years we'll have something different, more effective than either PPI, diet, or steroid. So I think you're well within a range of reasonable practice.
But nonetheless, there's clear evidence that if the patients continue to have elevated eosinophil counts, they have more complications from the disease.
I've had two patients recently with profound hypomagnesemia with PPIs, serious side effects. So I'm curious to know what your approach is. Do you screen for magnesium in your patients on long-term PPIs?
Sorry, I missed the first question. Your patients have what disease?
So they had very low magnesium.
Oh, very
serious,
low. Very low magnesium, yeah. I think it is reasonable, and I would do that, measure the magnesium and B12 periodically, maybe once a year, because it's so easy to replace, and it's so easy to correct.
Yeah, I've seen one patient with profound hypomagnesemia as well. It was actually pretty scary. I think that probably the patient should have a magnesium level checked once a year, just to make sure that there's no problem. Because as Edy says, it's really easy to just replace it.
There's one comment and one question. First of all, the question is, what is it in the milk that causes the problem? Can they have soy milk? Can they have almond milk? Or is it all milks? And then my comment is, my office spends more time discussing PPIs and possible adverse reactions than we do almost anything else. And I think it's time for our National Society to have a position paper we can just hand out. Here we are. This is safe. Please feel free to go ahead and take this medication.
Okay, for the first part, the milk, unfortunately, all those other milks, like soy milk and the nut milks, those two things are also in the 6-food elimination diet. So it's a tough one. And you want to take the other?
No, two things. First of all, that study that was on pediatric population, so it's yet to be seen that adults will respond to milk elimination the same. As far as the PPI, the scare is out there and it's very difficult to fight. Remember, when there is a study that shows that there is dementia, it gets lots of media. 5 years later, 2 years later, painstaking analysis that show there isn't, doesn't get the same coverage. So, that's something which, what our society says and the perception of people is going to be different, and I don't see a good way except of educating the patient, take the time, and be sure that you're giving it for the right reasons. Yeah.
I was just listening to that, what you were just saying. And what I find amazing is that you have a lecture at the beginning which talks about leadership. And when somebody gets up and says, we need leadership, and you say, we're not going to provide it.
So I
would say along the line that, as he said, the leadership is you, and you're going to end up basically educating the patient. It is not going to be 3 people that sit at the AGA. They're going to sit in your office and tell you what to do.
But I have to say, I think it would be reasonable for there to be some sort of position paper that says, this is what we ought to be doing. I mean, Michael's paper a couple of years ago was actually really good, and it did a lot to kind of debunk all of these potential side effects that turned out not to be important at all.
I think one page in from the AGA said, this is the AGA, we represent the gastroenterologists in the country, this is to the patients, one page about this is what we think.
That study that came out that you were talking about, I was at that study at the DDW, the author's paper was accepted by Gastro, and it's been published in Gastro.
We're really not just educating the patients, but we spend more time, all of us here, on this issue. It's amazing. We're not only educating the patient, we're fighting with the cardiologist. The GPs have absolutely across the board saying, do not use these drugs. And we continue to go against that. It's really, really difficult, very time consuming.
I think we'll take the break now. Maybe